As July 29 of 2022, the world has documented 22,485 cases of monkeypox, with 5,189 cases in the United States alone, making the United States the country with the most known infections amid the global outbreak. The World Health Organization has declared monkeypox a public health emergency, and although this disease has been known for years, certain features suggest that we are facing a very particular and unique outbreak with the potential for worldwide spreading. In this special podcast edition of Editors in Conversation, we will discuss the diagnosis and treatment of monkeypox with experts in the field who have dealt with significant number of cases in the United States. So the objectives of this podcast is to recognize the significance of the monkeypox outbreak, understand the approach for the diagnosis of monkeypox, and elaborate on the treatment approaches and prevention tools for monkeypox.
So this special episode is brought to you by the Journal of Clinical Microbiology and Antimicrobial Agents in Chemotherapy. I'm one of your hosts today, Ellie Thiel. I'm an editor at the Journal of Clinical Microbiology, and I'm joined by Dr. Cesar Arias, who is an editor, or the editor-in-chief at AAC. In today's podcast, like all of the other podcasts, they are supported by the American Society for Microbiology, which publishes both JCM and AAC. Don't forget to check out the latest issues of JCM and AAC, which have outstanding papers on microbial diagnostics, the mechanisms of resistance, pharmacology of antimicrobial agents, epidemiology, and clinical therapeutics, amongst other topics.
Ellie, this is an honor really to share for the first time the podcast between Journal of Clinical Microbiology and AAC. So this is also a momentous occasion. Thank you very much.
Thank you. I think this has been a long time coming.
Yeah. So joining us are very distinguished guests who are now becoming real experts in this field due to the outbreak. Jason Zucker is Assistant Professor of Medicine at Columbia University Medical Center and Infectious Disease Physician at New York Presbyterian Columbia University Irving Medical Center. And Dr. Benjamin Pinsky, who is the Associate Professor of Pathology and of Medicine and Infectious Diseases at Stanford University, and is the Medical Director of the Clinical Virology Laboratory for Stanford Healthcare and the Stanford Children's Health. And he's also the Editor-in-Chief of the Journal of Clinical Biology. So welcome to the program.
Thank you very much.
So Ellie, you start. Take it away.
I will. Thanks, Cesar. So Ben, we're going to start with you today. You know, I think many of us are probably somewhat familiar with monkeypox at this point, but just to kind of re-baseline us, can you talk a little bit about the virus itself? What type of virus is it? What's it similar to? Where is it considered endemic, and so on?
Absolutely happy to give a brief overview of the virology of this virus. First, though, I'd like to say that I was finally promoted today to full professor. It's official now.
Oh,
so.
Congratulations!
Thank you.
What a way to celebrate.
I haven't updated my bio yet. Anyway, enough about me. Let's talk about this really interesting virus. So it's a DNA virus. It's large. It has a very large genome, and it's related to, as everyone knows, smallpox or variola, and it's an orthopox virus with other animal viruses that are related, such as vaccinia, the virus that's used for vaccination against both smallpox and monkeypox, as well as camelpox, cowpox, and others. This virus has been endemic in Africa for some time. The exact sort of life cycle is not entirely known. It has been identified as infecting monkeys, but it's thought its primary host is some sort of rodent. And as people have read about and heard, the last large outbreak in the United States was due to the import of animals from Africa that then infected local prairie dogs and subsequently infected individuals that interacted with those prairie dogs. So why don't I turn it back to Ellie? So lots of interesting virology going on, and now, of course, the current outbreak is quite different than what we've seen previously in both Central Africa and West Africa.
Yeah, and just to kind of tag on, there's multiple clades, right?
Well,
Two.
yeah, sorry. There's two major clades. So these are initially were named, as I mentioned, based on the locations in Africa. So there's the Congo Basin or Central African clade, which is now termed clade 1. And then there's clade 2 and 3, which were found in West Africa, West African clades. And the current outbreak is due to that clade 2, clade 3 viruses.
So Ben, I'm sorry, Ellie, I just want to take your opportunity. There is this study in Portugal that suggests that the genetic difference of the current outbreak may be a little bit different from that clade and has a very particular genetic lineage. So the question that people tend to ask me is this a different virus? Do you think this is a new version of this virus? Will have a different phylogenetic sort of evolutive pathway?
Yeah, that's a really great question. I don't know that we know that quite yet. Certainly, the viruses that are part of this current outbreak are different than, are at least slightly different than the viruses that have been seen in previous outbreaks in previous years, even within this clade. But they're all quite similar to one another, is my understanding. So I think we'll have to see whether they meet the taxonomic definitions of new clades. Maybe this is just the start of the branching, and also what more sort of work on what these mutations do. Are they in important parts of the genome? What genes do they affect? How do they affect transmission and pathogenesis and so forth? I think there's quite a bit that we have to learn about this outbreak and the virus causing it.
Mm-hmm.
Jason, how many patients have you treated and dealt with right now? New York is, like in COVID, now the epicenter of this outbreak.
New York is definitely the epicenter of this outbreak. Our program has treated, I don't have numbers from today, but probably about 75 to 80 people at this point with medication for monkeypox.
Okay, so describe a little bit what you are seeing in terms of the clinical presentation from, what is classically described for monkeypox, what you're seeing now in the front lines.
Yeah, and I think that's a really important point is, many people were fooled initially because this is not presenting like classic monkeypox. Classically, it started like many viral illnesses with a prodrome of vague and nonspecific symptoms, things like fever, fatigue, malaise, muscle aches, headache, sore throat, cough, and classic swollen lymph nodes. And those usually started within 5 days of that, they developed the rash. In classic monkeypox, the rash can be on any part of the body, but the lesions develop simultaneously and evolve together. The rashes go through 4 different stages, starting as flat macules, then papules that look like pimples, fluid-filled vesicles, and a pustule with a central umbilication, and finally scab and fall off with new fresh skin underneath. While that's the classic presentation, that's not what we've seen during this outbreak. During this outbreak, the prodrome may or may not be present, and patients can actually start by presenting with the rash. While most patients do eventually go on to develop the rash is frequently starting in the genital or perirectal area. While lymphadenopathy remains a prominent symptom, many patients are actually having inguinal lymphadenopathy as one of their presenting symptoms. It's also notable that patients are having lesions in different stages of progression, side by side on the same body part, which is very different than our classic interpretation. The final thing is really the severity of this disease. While in general it's self-limited, for many patients can be a mild disease, for a percentage of patients, it's not mild and is much worse than many of us would have anticipated. We're seeing patients with severe pharyngeal disease, with cervical adenopathy, and challenging to take anything by mouth, patients with complex genital lesions becoming super infected, patients with urethral lesions causing extreme pain every time they urinate, and finally, probably most commonly, patients presenting with severe rectal pain, bleeding, and proctitis. And so for these patients, it's a much more severe disease than would have been expected.
So, Jason, have you seen any patient that tests potentially positive? We're going to talk about the test that doesn't have any rash, because that sort of mononucleosis-like syndrome that
Mhm.
has no rash and then turn out to be monkeypox.
Yeah. So I think one of the challenges in this country is that the currently commercially available assays are only available to do off lesion swabs. So we have had several patients that we would have suspected had monkeypox who presented with just proctitis. Their workup was negative for all the traditional causes of proctitis. But then they were negative for everything. And so we suspect monkeypox, but we're unable to validate it because we don't have a test for that.
I'm curious, Jason, you've seen a lot of patients. Have you seen any differences in presentation between patients that are maybe more immunosuppressed versus others? Are you seeing more severe disease?
So we've only had a couple of immunosuppressed patients so far, and I will say that at least one of them did have more severe disease. We know from the data from Africa that patients who are immunosuppressed may have worse or more severe disease. We luckily have not seen a lot of that so far, and fingers crossed we won't, but they have had pretty significant disease.
Got it. So we'll kind of move into testing. So Ben, for patients that maybe meet that do meet the clinical kind of criteria and risk factors that were just described, what testing options do we have at this point? And really, what sample type should really clinicians be submitting?
Yeah, that's excellent questions. There's now, after a bit of a slow start, a number of laboratories that are now offering clinical testing for monkeypox, including the Laboratory Response Network as part of the public health testing, a number of reference laboratories, including your laboratory at Mayo, as well as Quest and others. Excuse me. And then a number of academic medical centers, such as ours and many others across the United States, are now either offering or in the process of validating monkeypox testing. So I think we started slowly, but we're getting there as far as offering, having accessibility to more testing. The primary specimen of choice is a lesional specimen. These are the diagnostic specimens. They tend to have very high levels of viral DNA. And they can be collected either dry and then rehydrated in PBS or collected in viral transport media. We haven't seen any issues with that sort of collection. There's a lot of discussion about alternative specimen types that may be useful from a research perspective, trying to understand modes of transmission. And a number of articles now have shown that the virus can be detected in, say, oropharyngeal samples, in rectal swab samples, saliva, urine, and so forth. So how that sort of correlates with transmission should be quite interesting. It's probably not necessary that those are collected for diagnosis, but probably for research purposes. Although I should say that we have had one patient, I don't know why the patient had lesions. I don't know why they didn't collect them, but they told us to test his urine that was submitted for chlamydia and gonorrhea, which was positive for monkeypox.
Wow.
Yeah, oh, sorry, Ellie.
No, go ahead, Cesar.
No, just Jason just mentioned these cases in which people don't have a rash, and so in those cases, for example, severe proctitis. So, what kind of test you would recommend? I mean, rectal might be a bit difficult. What we would, oropharyngeal or any other would that be possible?
Yeah, sorry for my audio issues. I did not hear that, but yeah, I think in those patients that don't present with rash, these alternative specimen types are critical to make the diagnosis. I think an oropharyngeal swab would be very useful. And if one will consent for a rectal swab, I think that would also be useful. It's quite, especially in those patients with proctitis, they may have internal lesions that can't be seen without scoping. And so I think thinking about patients that don't have lesions is really important, that we identify those individuals as potentially transmitting the virus to others.
I'd say the other thing to maybe consider is it's not just monkeypox circulating, right? So probably making sure to order testing for other more common STDs like your HSVs and other potential infections.
Absolutely, with the co-infections, and I think that's been demonstrated in some of the large case descriptions, indicating that folks have other, they have chlamydia, gonorrhea, syphilis, other things that need to be considered. Mm-hmm. The individuals are at risk for all STIs.
Yeah. So I have to ask this because I'm getting more and more questions on the topic, and want to make sure I'm telling them the right thing. So what are your thoughts on the role of serologic testing for monkeypox? Because if you look at the CDC kind of case definitions, there is an IgM serologic test that's included, I think, for probable monkeypox. So curious what your thoughts are on current or future roles for monkeypox serology.
Oh, that one's for me.
That one's for you. But Jason, you're welcome to chime in as well.
You're the serology expert, I think.
I'm learning here.
But we will hear Ellie's experience too.
You're taking moderator hat. I see.
Correct.
I am in general skeptical of IgM testing for the use of IgM testing for the diagnosis of acute infectious diseases, except for very specific cases. And I'd worry in particular about IgM, particularly if folks may have been. I don't know I don't know its performance characteristics for this outbreak. I don't know that anyone does. As far as serology overall, there's a large swath of the population that's old enough to have been vaccinated. So there's that concern for cross-reactivity. I think that the serologic assays will really need to be worked on to determine their performance characteristics, what are the right antigens to use, whether one should delve into IgM and all of its associated problems, or whether IgG would be better, at least for epidemiological surveys. But I think that the nucleic acid amplification testing works really well for diagnosis, and that should be the primary diagnosis. And perhaps we'll see rapid antigen testing because the lesions have so much DNA and likely so much antigen that may be a viable option. But I guess for me, I would stay away from IgM testing at the moment.
Yeah.
So Ellie, what do you think?
So let me tell you what I think. So I put the monkeypox IgM testing in the same bucket as HSV IgM testing, right? We're looking for acute disease or acute infection with these IgM assays. And when you have PCR, I mean, why bother? So I am not, jumping to validate a monkeypox serology test as of yet. So I'm glad we're on the same wavelength there.
Yeah, I don't know. Maybe you know what the performance characteristics are of the test from the CDC and whether it's even widely available.
So it is available through the CDC, but I haven't really seen performance characteristics of it yet. The question is, in the future, would we want/need an IgG assay to look for past exposure? Maybe. But I think we're a ways away from needing that as well.
Yeah, it seems like that. I mean, the serology might be very interesting for epidemiologic survey to see how much of the population may have been infected, with all the caveats of cross-reactivity with vaccinia vaccination.
Yep.
But I don't know. I don't know whether it will be necessary as a clinical test. It seems at the moment unlikely, but who
Yeah.
knows?
So, Jason, any diagnostic challenges in New York?
Not as many now. Early on, obviously, as in any epidemic, it was a challenge to get testing done using just public health labs because obviously they have less resources and less ability to test large volumes. Since the commercial labs have come online, it's been great. We've been able to send samples without an issue, get results back in a timely manner. The biggest remaining obstacle is sort of what we talked about before, the ability to test things other than just lesions. While most of our patients have presented with lesions, we've seen data from Canada and Europe that demonstrates people who test positive on other sites without having skin lesions. And we believe we've seen several of those so far, but have been unable to test them and confirm the diagnosis.
Excellent. Let's talk about now treatment, Jason.
Sure.
So tell us in general what options. So we have antivirals, we have vaccines, and we have probably immunoglobulin potentially to do that. Let's talk about the antivirals at this moment, which we have for other disease like smallpox. So tell us about which drugs are you using and how is it to get them?
So, there's 3 antivirals the CDC always talks about. There's Cidofovir, which many of us have used, is commercially available, but obviously very nephrotoxic. There's Brincidofovir, which is closely related to Cidofovir and theoretically less nephrotoxic. The CDC is working on an expanded access IND for that one right now, but currently that's unavailable. And really the agent that everyone is pushing for now is tecovirimat, which is a drug that the CDC has been encouraging the use of for this outbreak. It's a novel antiviral that works by inhibiting the VP37 protein and preventing formation of intracellular enveloped virus from intracellular mature virus, stopping virus development and keeping it from leaving the cell. There's really a lot of excitement about tecovirimat right now. You hear about it in the news, on Twitter, on message boards. But I think one of the really important things to know is that we don't really know yet enough about it. The CDC has made it available through this expanded access IND process, which allows them to keep collecting data on it while increasing access to it and making it more available. We have no human efficacy data. All of the efficacy data comes from non-human primate studies. And so we don't know necessarily that it works. At the same time, we also have very limited safety data. It was approved through the FDA animal approval process for smallpox as an agent if needed for a smallpox outbreak. In terms of safety, the only published data we had before this outbreak was safety data in 359 people. And so while we knew it was safe in that number of people, you don't know if there's more rare serious adverse events that are not being picked up in a small study like that. The good thing is more doses than that have been given out or more patients than that have been treated during this outbreak already. And thanks to the expanded access IND process, we can collect some of that safety data and have a better idea of the overall safety of this medication. And that really helps in that case. The other question being efficacy is much more challenging to answer in a disease that we know is for most people self-limited. And so we really do need a placebo-controlled, randomized controlled trial to answer the question about whether this drug works. So we know whether we spend so much time and effort delivering this drug to people or we need to be looking for other things.
Yeah, and in our experience with cidofovir, the nephrotoxicity is always an issue.
Right.
Drug that you give, and then the published literature with brincidofovir is now a hepatotoxicity that the drug has been discontinued. So it leaves tecovirimat as the main horse, here for that. So what is your experience giving tecovirimat? I mean, do you feel that the drug is working, that is not? I mean, I'm very curious to see what you think about it.
Yeah, I try to stay out of making decisions about it in large part because I'm the one doing informed consent with my patients and I don't want to bias them too much. I will say that the vast majority of patients we've started on treatment have done very well and have seemed to improve pretty quickly. I will also say, though, that we're not currently offering treatment on the weekends. And there are patients we have on Fridays that we call by Sunday and have also improved. So while it feels like it's working overall, I think until we really have that randomized controlled trial, we're not going to know the answer about whether it's actually working or patients just get better on their own. But it certainly would be very important to have a drug that works for this disease, especially given the severe manifestations we're seeing during this outbreak.
And how easy is it to get there in New York right now?
So it depends a little bit on where you're located. The New York City Department of Health has really done a fantastic job trying to roll it out. They've provided a lot of technical assistance to get working through the regulatory hurdles and through the IND process. With that said, the IND still makes it more burdensome that not every clinic can fulfill the paperwork. The 3 visits required for every person started is a lot. We've started about 75 people, so that's 225 visits we need to be able to support, because each person needs 3 total visits. And then there's now, I'll give the CDC a lot of credit. They've really reduced the amount of paperwork the IND requires, but they have not eliminated it. And so there's still a decent amount of paperwork and additional work for each patient seen that needs to be done. And so primarily the major academic medical centers, the ones that have additional staff or research teams or other teams that can be repurposed to do this, can offer it. But it can't be offered at every clinic at the moment because it's just too burdensome.
Yeah. Any comments for the other panelists? In Texas, we're having exactly the same problem, that we have the resources and researchers and coordinators to fill out paperwork because, with the clinical busy schedule and all that is going to be very difficult. I'm not sure how it's in Palo Alto or in Mayo, in Rochester.
I don't think I can comment. I'm not sure, to be honest. I did look at all of the paperwork required, though, and there's like 7 or 8 forms, which is, kind of a lot. So I can definitely see that being a drain on resources for sure. Can I follow up? 3 visits per patient. That's for 3 treatment doses. Is that correct?
No. So the way the CDC has it set up, there's an initiation visit, so starting the patient on treatment, and there's an intake form. And then they've now updated, so there's just 1 outcome form, but that outcome form wants data from 1 on treatment visit and 1 off treatment visit at the day between days 7 and 10 after completing treatment. So there's sort of 3 visits needed. They have explicitly said in the updated one that these can be done remotely, which is a huge help, especially for patients who don't have disease that necessarily needs to be followed in clinic. And so by explicitly stating that, they've made it a lot easier. They've also explicitly stated that labs are optional, which again makes it easier to do remote visits. So they've really reduced the amount of burden on it, but it's not nothing. You still need to have those 3 visits to be able to complete the 2 forms at the 3 time points.
What happens if you don't complete the forms?
Don't know.
I'm not suggesting we do that, but
I don't know. It's an IND process, and so you do agree up front that if you're going to participate, you're going to complete the forms. I will say that at times some of our forms have maybe been slightly delayed from what the CDC has asked for, just due to volume. It's been hard to keep up. But we have turned all of our forms in, and will continue to. So I don't have to find out what happens if I don't complete them.
Sure. Okay, so moving away from forms, Ben, many of us in the labs have become a lot more adept at viral sequencing and to track viral evolution, which has obviously been really important for COVID-19. But do you think that this is going to be equally important for monkeypox in the current environment?
Yeah, I suspect that we won't need to do as extensive of sequencing of monkeypox as we have had to do for SARS-CoV-2. It's not likely that this virus is going to change as rapidly or be under the evolutionary pressures as strong of evolutionary pressures as SARS-CoV-2 has. However, I think certainly at the beginning here, we should better understand the virus. And whole genome sequencing should help with that. It probably does not need to be done for every single sample, but getting more information about the changes compared to previous outbreaks and identifying whether there are ongoing changes in the genome. And like I mentioned earlier, where those changes are and do they impact transmissibility or pathogenesis would be important to monitor.
Sure.
So do you think, Ben, that even though maybe the changes are not that dramatic, the lack of information about the antivirals and all that will justify much more routine of whole genome sequencing of this virus to understand more the kinetics of the viruses and emergence of resistance?
Yeah, I mean, I think that that's an open question. In how does the genome change in response to the antiviral? It's not clear that we know that at present. Um, Whether this will be something that many clinical laboratories now are performing SARS-CoV-2 whole genome sequencing as a sort of aid to our public health colleagues, and to make sure that we know the local sort of the local variant landscape, if you will. I'm not sure that level of surveillance is going to be required for monkeypox, but I completely agree that additional sequencing is going to be important in understanding all of these questions, particularly the effectiveness of this new drug.
The other question I had is like, now we are seeing, so the population that was initially described, this outbreak, now things are getting out of that population. We're seeing children now infected with this, pregnant women on this situation. So I guess deploying these tools into these populations is going to be important, and that's what I'm saying, that from a pure transmissibility point of view, I think that's very crucial. And there's some now deaths described as well, and severe presentations, that is a little bit scary. So any comments on that? Jason?
Yeah, I mean, the reports coming out, particularly over the last 24 hours, of between 4 and 5 deaths around the world, particularly related to what sounds like encephalitis, is obviously very concerning. We've heard that this disease could be associated with encephalitis. I know there's been at least one case I've heard about in the United States, although not seen myself, but it's obviously something we're certainly on the lookout for. And certainly something to worry about, even if it's a small number of people. If a large number of people are infected, then you can get a large number of people really sick.
Okay, let's talk about vaccines. I think we've lost Ben for a little while. So since we're getting back, Jason, let's talk about vaccines. There are 2 vaccines that have been used. One which is a replicative virus, the non-replicative, which is the one that probably everyone is using. Yeah. So have you used this vaccine? Can you tell us something about these vaccines and how they were going to be deployed?
Yeah. So, the first one's the ACAM 2000, which I don't believe has been deployed yet as part of this outbreak. That's the one that contains the replication-competent vaccinia virus. It's held in the Strategic National Stockpile, and there's a lot of it there for a potential smallpox outbreak. It's a single-dose vaccine, which is nice, and given through the percutaneous route with the multiple puncture technique, so sort of older school style. But I don't believe that anyone has started to use that during this outbreak so far. The one that everyone's using so far is the Jynneos vaccine. This is the one that's actually FDA approved for both smallpox and monkeypox for those age greater than 18. It's an attenuated live virus, and it's replication deficient. And so I've gotten a lot of questions about this from different services talking about immunocompromised patients. This one is thought to be safe for immunocompromised patients, including patients living with HIV, even with low CD4 counts. It's given us 2 doses separated by 4 weeks apart. I know that many jurisdictions now are currently prioritizing first doses, but we really don't have any data on just giving a single dose. And so it's really challenging to extrapolate what that means.
So have you seen this being deployed in the communities, particularly in these sexual networks where the initial outbreak was described? And
absolutely.
And do you think that has had an effect?
So it's hard to say because it's still early. So, the data on the vaccines are that the best immune response is 2 weeks after your second dose, which we're not doing, nor would you be there yet. And that even for first doses, it's probably 2 to 3 weeks before you're seeing a significant enough immune response to be protected. New York City has rolled out this vaccine at their vaccine clinics with a focus on the epidemiological risk group. So they've sort of made it so that you have to be in the epidemiological risk group to be vaccinated. They've reached out to community-based organizations like our HIV prevention program to assist with referring patients at highest risk to try to get to the vaccination to those at most need right now. I think it'll be a little bit of time before we see it now. I don't know if anyone is at IAS or has been at IAS, but I heard that the city of Montreal, who really got started early with vaccination, was going to present some of their data. And hopefully that'll be positive and reassuring, looking at a decrease in cases 2 to 3 weeks after their vaccination program launches.
And sorry, Ellie?
Yeah, just curious. So there's vaccinia immunoglobulin as well.
Mm-hmm.
Is that being used or considered to be used in any patients?
So you can do that through the CDC. I have not come across any patients who would need that. There has been discussion about using it in patients who are high risk, who can't receive vaccination for one reason or another, or might be immunocompromised enough to not respond to vaccination, but have been exposed. I haven't had any patients who sort of met that criteria yet, but I know it's been talked about a lot.
Yeah, we haven't used that either at this point. And Jason, we have all these people talking about vaccines and that they don't like vaccines. I don't want to mention specifically how they are called sometimes, but there is reluctancy. So is the uptake of these high risk groups been okay compared to, for example, the COVID-19? I think my sense is that there's been a much more openness to receive the vaccine in these populations.
I think that's definitely true. I'm med peds trained, and so on the peds side, we deal with people who are less pro-vaccine frequently. My sense has been that people have been very interested in receiving the vaccine. The caveat to that is that when these things are first launched, especially when there's limited supply, you see that there's more demand than there is supply. And then as more and more people get vaccinated, you sort of see who's left and whether those people don't want to get vaccinated because they haven't been able to, or don't want to get vaccinated because they're really not interested. So far among my patients, the uptake has been really strong. I think that has a lot to do with the fact that there's a lot of stigma around this disease, more so than we've seen in a long time, more so than I see with sexually transmitted infections in my clinic, sort of a much heavier stigma around this disease. And I think that plays into people wanting to get vaccinated to try to prevent it and protect themselves.
Mm-hmm. Mm-hmm.
That sounds like the HIV at the beginning.
It sounds a lot like HIV at the beginning. I was a little shocked initially when we first started diagnosing patients about just sort of how strong the stigma was and how upset they were about the diagnosis. Even patients with pretty mild disease have been taking it very hard. And so it's important that we're making sure that we're cognizant of that fact and offering mental health and other resources, because then after that stigma and diagnosis, then they're trapped at home for 4 weeks alone. So it's sort of a really hard disease from a mental health standpoint.
Mm-hmm.
Yeah, the other aspect that I just as a final commentary is the isolation period for people. If you get, bad luck enough, or you have healthcare workers isolated, because it's not only it's going to be weeks of people, healthcare workers, and that will be, if this increases inside, that will be a massive blow to the whole healthcare workforce. So I hope that doesn't happen and we don't get. Ellie, your final word?
My final thoughts, I'm happy that from a testing perspective, we're in a better place than the last major outbreak pandemic. So that's, that's a positive silver lining in this case, I suppose.
So I just want to thank everybody now for this wonderful conversation. I am going to thank my co-host, Dr. Thiel. This is a wonderful, and we should do this more frequently. And this is a wonderful situation in which we can change and get to people. This is a public health emergency, and we're glad that we have the ability to talk to you guys to help people managing this problem. Thank you very much. This is Cesar Arias, co-host of Editors in Conversation. And Ellie, you want to say goodbye to the podcast?
Yes, thank you both for joining us today and sharing your thoughts and knowledge on it. I know this is, a big question out in the community, so lots of discussion. So thanks for joining us. And Cesar, it was a pleasure.
Thank you very much.